Hey everyone! If you're anywhere in the world of pediatric nursing, maybe you're prepping for exams or you just need a really solid refresher, you are in the right place. Today, we're going to crack the code on congenital heart disease. We're going to focus only on the super high-yield stuff, the things you absolutely, positively have to know.
All right, let's just dive right in with a question. What do you think is the single most common type of birth defect out there? Any guesses? Well, if you said congenital heart disease, you absolutely nailed it. We're talking about nearly 1 in every 100 newborns. Think about that for a second. That's precisely why getting a handle on this topic is non-negotiable for anyone in peds.
So, here's our game plan. First, we'll lay the foundation. What even is CHD? Then, we'll tackle the Great Divide, the two main types. After that, we'll zero in on some exam favorites, and we'll wrap it all up with the clinician's playbook for nursing management. Sound good? Let's do it.
Okay, Section 1, the foundation. Let's get right to it. What exactly is congenital heart disease?
Okay, the number one thing you got to remember is this. CHD is a structural problem. It's a plumbing issue, all right? Something in the heart's actual anatomy, or in those big vessels connected to it, just didn't form quite right. And congenital just means it was there from day one, from birth. And that one little flaw, well, it messes with the heart's entire job, which is just to get oxygen-rich blood out to the body.
So you're probably wondering, what causes this? And, it's complicated, but we do know some clear risk factors. On the maternal side, think about things like certain infections during pregnancy, like rubella, or maybe uncontrolled diabetes, or exposure to things like alcohol or specific drugs. Then you've got the genetic piece of the puzzle. Conditions like Down syndrome and Turner syndrome, they come with a much higher risk. And of course, if it runs in the family, that's a big flag too.
Okay, everybody, lean in for this next part because this is it. This is arguably the single most important concept you have to nail down for your exams and for real-world practice. We're talking about the Great Divide in CHD, Acyanotic versus cyanotic. If you understand this, you understand the core of CHD. It's everything.
So look at this. It seems complex, but it all boils down to one simple thing. Which way is the blood shunting? That's it. For acyanotic defects, you've got a left-to-right shunt. Think about it. The left side of the heart has higher pressure and oxygenated red blood. So that blood takes a wrong turn and goes back to the right side, back to the lungs. The result? The lungs get totally flooded. That's your pulmonary congestion. Now, flip that for cyanotic defects. Here, you have a right-to-left shunt. The deoxygenated blue blood from the right side bypasses the lungs completely and gets shot straight out into the body. And what do you see? Cyanosis, that bluish tint. It's all about the direction of the flow.
So how are you going to remember the acyanotic ones, the ones with the left-to-right shunt? Just focus on these big hitters: atrial septal defect, ventricular septal defect, and patent ductus arteriosus. You'll also see AV canal. These are the defects where that oxygenated blood is taking that crazy detour back to the lungs. And the key takeaway? These babies are typically not blue, at least not at first. They're pink.
And what about the cyanotic ones, the blue babies? Oh, this one's a classic, and you have to know it for your exams. It's the 5 T's. Super simple. All 5 of the big ones start with the letter T. We're talking Tetralogy of Fallot, transposition of the great arteries, Truncus arteriosus, you get the idea. So when you're in an exam and you see a defect that starts with a T, I want you to immediately think T is for trouble, T is for terrible, T means blue baby, right to left shunt. Got it?
Let's just walk through the chain of events for cyanotic defects one more time. Step 1, you have that left to right shunt. All that extra blood gets dumped back into the lungs. Step 2, increased blood flow to the lungs. Step 3, what happens when you flood the lungs? You get pulmonary congestion. It's like a swamp in there. And step 4, that constant extra workload, that volume overload, it just wears the heart out. And that leads directly to heart failure. Simple as that.
Okay, now let's trace the cyanotic path. Step 1, you've got that right to left shunt. This means, step 2, that deoxygenated blood is completely bypassing the lungs. It's not getting that vital shot of oxygen. So, step 3, you have low oxygen pumping all throughout the body. The immediate result? Cyanosis. And over the long haul, that chronic lack of oxygen can cause clubbing in the fingers and toes.
All right, let's move on. Now we're going to zero in on a few specific defects that are, let's be real, absolute exam favorites. If you're short on time and you can only memorize a couple of these conditions in detail, make it these ones.
Let's just do a quick compare and contrast here. First up, VSD, ventricular septal defect. This is the most common one, period. You're looking for a loud murmur and that classic failure to thrive or poor weight gain. Then you've got ASD, Atrial Septal Defect. This one can be a little sneaky. Sometimes kids are totally asymptomatic. And then there's PDA, Patent Ductus Arteriosus. This one has a super unique sound. They call it a machinery murmur. It's a continuous roar. And check out the treatments. A VSD might just close all by itself, which is amazing. But for a PDA, we can sometimes close it just by giving a medication, indomethacin. Pretty cool, right?
Okay, so we've talked about the 5 T's, but if you have to become an expert on just one of them, it has to be this one, Tetralogy of Fallot, or as you'll always hear it, TOF. This is, without a doubt, the classic poster child cyanotic heart condition.
So tetralogy literally means a group of 4. So what are the 4 defects that make up TOF? You're never going to forget it if you just remember the mnemonic PROVE, P-R-O-V-E. So P is for pulmonary stenosis. That's a narrowing of the pulmonary valve. R is for right ventricular hypertrophy. The right ventricle gets all beefed up and thick from working so hard. O is for an overriding aorta. The aorta is basically in the wrong spot, sitting over both ventricles. And V is for a ventricular septal defect, a VSD. Put those 4 things together, and you have the perfect storm for that right-to-left shunt we talked about.
Okay, pen and paper time. This is a 5-star, must-know NCLX favorite topic, managing a TET spell. A TET spell is when an infant with TOF suddenly has a hypercyanotic episode. They get very, very blue, very, very fast. Your response has to be lightning quick and in this exact order. Do not mix these up. Step 1, and the first thing you do, put the infant in the knee-chest position. Tuck their knees up to their chest. This move is magic. It increases pressure in the body and shunts more blood to the lungs. Step 2, blast them with 100% oxygen. Step 3, give morphine. Why morphine? It calms the baby down, which reduces their body's oxygen demand. Maybe even some IV fluids after that. But you have to remember, knee, chest, oxygen, morphine. In that order. Drill it into your brain. All right, let's bring this all home to the bedside. Let's get into our final section, the clinician's playbook. This is all about the practical, hands-on nursing management. What do we actually do for these incredibly fragile little patients?
So, when you're building your care plan, everything is going to circle back to these core diagnoses. Of course, you've got the big ones: impaired oxygenation and decreased cardiac output. Duh, right? But please, please don't forget about imbalanced nutrition. These babies are working so hard, they burn a crazy amount of calories just to breathe, let alone eat. And because they're so tired, you get activity intolerance. And of course, all of this puts them at a huge risk for infection. Now, the pharmacology for these kids is super interesting. Some of it is what you'd expect, right? We use diuretics like furosemide to get rid of that extra fluid from heart failure. We might use digoxin to help the heart squeeze a little harder. But look at this last part. This is really cool. Sometimes that patent ductus arteriosus, that PDA, is actually life-saving. We need to keep it open to allow blood to mix. And to do that, we give a medication called prostaglandin E1. But in other cases, we want to close the PDA. And for that, we use an NSAID like indomethacin. So you have one drug to keep it open and its opposite to close it. Knowing which one to use when is absolutely key. When it comes down to it, our nursing care is just a constant, delicate balancing act. It's all about strategy. For oxygenation, we're using things like the semi-Fowler's position and oxygen therapy. For feeding, our strategy is small, frequent, high-calorie meals. It's all about conserving their energy. For infection, we have to be absolutely militant about hand hygiene and keeping up with their vaccinations. And to prevent them from getting exhausted, our best strategy is to cluster our care. Do everything you need to do at once and then let that baby rest. Give them those long, beautiful periods of uninterrupted sleep. Whew, we've covered a ton of ground, haven't we? From the simple physics of blood shunts all the way to the critical, life-saving steps for managing a TET spell. So I'm just going to leave you with this one question to really think about. Now that you have this framework, how are you going to be that clinician? The one who hears that subtle little murmur that someone else might miss. The one who questions why a baby isn't gaining weight. How are you going to be the one who spots those signs early and literally changes a child's entire life? Because that's the power you have with this knowledge. Thanks so much for hanging out with me for this explainer.